right. Welcome to my program on teaching psychopharmacology using research domain criteria. It's a brand new world, isn't it? Doing things from home with no audience. So welcome to the challenge. So what is research domain criteria? Research domain criteria is an alternative to the Diagnostic and Statistical Manual of the American Psychiatric Association and to the corresponding International Classification of Diseases method of diagnosing mental disorders. It's the one preferred by the National Institutes of Mental Health, and it turns out that nowadays one must use research domain criteria to obtain funding from the NIMH. So why? It's because contemporary DSM diagnoses are not based in neuroscience. Contemporary DSM diagnoses are overlapping, contradictory, vague, and hinder research. So we need diagnoses that are based in brain circuitry and function rather than expert opinion. So what are the ideas upon which this is based? First, that psychiatric disorders are brain disorders with a primary focus on dysfunction between neural circuits and networks. So disconnectivity and abnormal connectivity, which contrasts with neurological disorders that have identifiable structural lesions. We'll spend some more time shortly on brain circuitry, but these brain circuits include the reward circuit, fear extinction circuit, executive function circuit, impulse control disinhibition circuit, to name a few. So research domain criteria assumes that dysfunction in neural circuits can be identified with the tools available to clinical neuroscience, including EEG, functional MRI, evoked potentials, magnetoencephalography, and things like PET scanning and things like that. And it assumes that data from genetics, epigenetics, and clinical neuroscience will ultimately yield bioprints or biomarkers which will improve our recognition of patients' clinical signs and symptoms. So, part of this idea is that psychiatric disorders are also neurodevelopmental disorders. So, the maturation of neurons interacts with external influences beginning at conception. So these external influences include prenatal infections, early childhood abuse and neglect, and trauma. The criticism of DSM is that it does not provide integrative developmental models that differentially lead to resilience or to psychiatric disorders. And DSM diagnoses do not provide us with an understanding of why a particular insult may lead to a specific disorder. For example, early life stress is a risk factor for major depressive disorder, post-traumatic stress disorder, and borderline personality disorder. So our standard approach, which I know everyone listening is completely familiar with, our standard approach is that we define a mental disorder by signs and symptoms, and then in essence, we perform a lookup function and seek a diagnosis that corresponds to those signs and symptoms. And because of the overlap, people can have multiple diagnoses. So research domain criteria asked, what is the normal distribution for a certain trait or characteristic? And when does it become abnormal? When does it fall outside of the normal distribution? Or we might say, when does it fall outside of 2 standard deviations from the norm? And we ask, what is the brain system that implements this function? And how can we understand what accounts for the development of dysregulation or dysfunction in these symptoms alongside normal to abnormal dimensions? So the idea is that everything is on a continuum, and that abnormal would consist of the extremes of the continuum in either direction. And so what we're interested in is looking at a connectivity-based approach that emphasizes the role of network-mediated integration across brain regions, and not the idea that problems arise from specific brain regions themselves. So we're looking not at a lesion-based approach, but rather what's called a connectomic paradigm. We're looking at disconnection of circuitry, of brain regions within particular circuitry. And the idea is that particular neural circuits can use the same brain region for different purposes. So, getting back to the shortcomings of DSM is the extensive comorbidity among diagnoses. And I know that all of you have seen patients with multiple psychiatric diagnoses. And as part of that, there's an overspecification of categories and an overuse of the not otherwise specified diagnoses. So DSM categories do not represent current knowledge about genetics, neural circuits, neurotransmitters, and behavior. So, so we want to move away from the old approach and in which the presence or absence of disease sorts individuals into distinct groups. And this between groups approach ignores the substantial number of individuals whose number or severity of symptoms places them in between diagnostic categories or in subclinical spheres that are often ignored. And so research domain criteria intentionally omits any disease definitions, disorder thresholds, or cut points for various levels of psychopathology. And we'll get into how one works with that in a moment. So we're talking about a continuum approach. And the idea is that some degrees of, for example, psychotic phenomena are present in everyone and in broad ranges of psychiatric outpatients, which is true for depressive phenomena, dissociative phenomena, hypervigilant phenomena, etc. And consistent with this view is that symptoms are arrayed across a population and not the manifestation of qualitatively distinct severe pathology. And so another way of saying that is everyone is a little bipolar. Everyone is a little psychotic. Everyone is a little manic. Some are more than others. And what we're interested in is when the traits and the characteristics of people become so severe as to render them unable to function or as to cause undue suffering. So let's look at some foundational ideas for how we work within this paradigm and how we're teaching residents to think about psychiatric diagnoses and psychiatric prescribing. So most Cochrane meta-analyses and particularly those from the Oxford University Research Group of Adriana Cipriani have found that drugs within any given class are generally the equivalent in function. What differs are their side effect profiles. So, for example, there's no particular antidepressant that's any better than any other antidepressant. Similarly with anti-anxiety agents, there's no particularly anti-anxiety agent that is better than any other. Now, there are subtle differences. For example, Cipriani found that venlafaxine is a tiny bit better than the rest. Fluoxetine is a tiny bit better than the rest, but not hugely so. And however, some classes are better than others. And surprisingly, the SNRIs and the SSRIs are substantially better than the benzodiazepines for treating anxiety after 12 weeks. The benzodiazepines are better before 6 weeks. Between 6 and 12 weeks, they begin to blur. And, but nevertheless, within SSRIs or SNRIs, drugs are essentially equivalent. The same is true with antipsychotics. And it's also true in terms of efficacy between first generation and second generation antipsychotics, with some subtle differences that we'll discuss, but again, subtle differences. The second thing that I tell our residents is that while you may need to know what is FDA approved for your board exam, that doesn't necessarily apply to clinical practice. FDA approval is a lengthy, expensive process, and companies will not necessarily engage in this process if they don't see a profit accruing from that engagement. So FDA approval is not equivalent to clinical efficacy. Third, what the drugs are called is marketing and doesn't necessarily describe what they actually do. So antidepressants, for example, are better for anxiety than they are for depression. In fact, for depression, they barely work better than placebo. And in some studies, they don't work better than placebo at all. Antipsychotics work for depression. They can work for anxiety. They can work for many things other than psychosis. Fourth, psychiatric diagnoses are for billing. They don't necessarily explain the patient's experience or help us to choose a medication. So in clinical practice, we treat symptoms and not diagnoses. And my approach is to treat the most disturbing symptom first. And a corollary to this is that we don't make people symptom-free. It's just not possible with medication. And once upon a time, we knew this, And in fact, there's an excellent book, older book now, called Dysfunctional Affect. And the idea of the book was that the purpose of medication is to reduce dysfunctional affect to a level at which the patient can engage in psychotherapy. We in psychiatry, sadly, have created the misperception, or the false belief, I might say, that with medication alone, we can make people feel fine. And I just haven't seen it. If anyone out there has, please email me. The sixth foundational idea is that mostly psychiatric prescribing is trial and error. And there's no perfect algorithm for prescribing. Now, the best algorithms come from Texas. They are the Texas medication prescribing algorithms. And even those algorithms admit that if the first drug doesn't succeed, try the second drug. And if the second drug doesn't succeed, try the third drug. The Texas medication prescribing algorithms work better than psychiatrists not using an algorithm. Now, that having been said, we have large placebo and nocebo responses. People improve dramatically if they think they're going to improve. People can get worse or have side effects if they think they're going to get worse or have side effects. Therefore, if a patient is enthusiastic about a particular drug based on a friend's response or a family member's response, I'll try it because I'll take the placebo effect. It's at least 48% of the response, and in some studies, more than 60% of the response. And a seventh corollary is that genetic testing in psychiatry is not all that useful. And surprisingly, Harvard University psychopharmacology courses agree with me. The genetic testing does not tell you if a drug will work. It only tells you if the patient is a rapid metabolizer or a slow metabolizer of that drug. It doesn't guide one's choice of medications. I only use it when someone is at the top of the dosing range, and I want to know if I can increase the dose beyond the maximum recommended dose provided by the manufacturer. This would be in the case of a partial response, and I want to know if I can go higher. So if they're a rapid metabolizer, I can go higher. If not, then I may want to stop and consider adding a second agent. And if they haven't responded at all, and I'm at the maximum dose, then why would I want to continue with that medication? So let's think now about what are the actual drug categories. So some drugs modify serotonin receptors, both pre- and post-synaptic receptors. These would include the SSRIs, the tricyclics, and the SNRIs. And interestingly enough, we now know that the mechanism of action of SSRIs is not due to the inhibition of the reuptake of serotonin. So even those names are misleading. But nevertheless, they do work upon serotonin receptors. Then we have drugs that modify norepinephrine receptors. Again, tricyclics, SNRIs, drugs like atomoxetine, which is a purely norepinephrine receptor agent, beta and alpha-adrenergic blockers, things like that. Then we have amphetamines or stimulants, most of which increase dopamine. Some tricyclics, like desipramine, function in this way. The psychostimulants function in this way. Modafinil functions in this way. Then we have drugs that are dopamine agonists. Bupropion is an example of this. Tricyclics can function as dopamine agonists. Things like ropinirole are dopamine agonists. And one of the crazy things to me is when people give both a dopamine agonist and a dopamine blocker. So we see people on ropinirole and also olanzapine. Dopamine blockers, these are the first and second generation antipsychotics, but they also do things to other receptors too. We have direct GABA agonists, which are the benzodiazepines. We have voltage-gated sodium channel blockers, which are the anticonvulsants, some of which also enhance gamma-aminobutyric acid function. We have drugs that reduce the release of glutamine. So these would be anticonvulsants and some calcium channel blockers. We have the anticonvulsants that act as peroxisome proliferator-activated receptor agents. We have medications which reduce pro-inflammatory cytokines. And there is much discussion about the role of inflammation in psychiatric disorders. And in fact, there are reports of controlling mania with NSAIDs. And I've actually seen that personally, that high-dose NSAIDs can terminate a manic episode. So SSRIs and NSAIDs reduce levels of pro-inflammatory cytokines. So we can't go far in life without a quote from Rumi, and this is one of my favorites. "Study me as much as you like, you will not know me, for I differ in 100 ways from what you see me to be. Put yourself behind my eyes and see me as I see myself, for I have chosen to dwell in a place you cannot see." This is the challenge for psychiatric diagnosing, that we need a phenomenology. We need to explore the lived experience of the patient. We need to understand the symptoms of the patient from within the patient, and not from these categorical systems that resemble botany, that are replete within the DSM. So what are the categories of symptoms that people bring to us? So one of them is what Panksepp called loss of seeking, and we'll speak a little bit about Panksepp shortly. But so these symptoms consist in excess sadness, hopelessness, helplessness, lack of agency, indifference, abulia, which is one of my favorite words, meaning loss of motivation, loss of interest, so collapse. A second category of symptoms consists of excess worry, ruminative thoughts, hypervigilance. A third category is decreased attention, scattered focus, distractibility, fatigue. A fourth category is excessive seeking, so racing thoughts, hyperactive behavior, quick shifts of attention. A fifth category is failure to error detect, which is so important in bipolar and psychosis. And almost the essence of mania is that people lose the capacity to determine that their behavior is not producing the effect that they desire. So failure to detect error. A sixth category is decreased executive function. A seventh is excessive fear, freezing, sense of constant danger. You might think of this as amygdaloid overload. An eighth category is paranoia, or excessive attribution of external agency. A ninth category is dysnarrativia, meaning that people can't tell a coherent story about what's going on in their lives and with them. 10, disorders of salience. People can't figure out what matters, what's important. Everything seems equally important. 11, we have disorders of sleep. 12, we have emotional dysregulation. So the inability to self-soothe or to calm oneself. So there are brain circuits that subserve all of these functions. So, and this is the challenge, because if we're going to work within research domain criteria, we have to throw away our cookbooks, our DSM, and begin to study the neural circuits. So, and begin to think about, so what are the neurotransmitters that are involved in these neurocircuits, and how can we intervene pharmacologically to alter the function of these neurocircuits? And here's the rub. So receptors in the brain are really smart. Whatever you do, the receptor will overcome it in a period of time, generally about a year and a half. And so it's well known in psychiatry that one has to keep increasing the dose, or after a period of time, switch medications or switch classes of medications to get the same effect, because the receptors figure out how to overcome what we're doing to them, which is why once upon a time we said, well, the medications give us a period of time in which we can do the psychotherapy and work within a psychobiosocial paradigm to change the external context of people's lives so that their brains will function differently. And one of the astute findings of contemporary neuroscience is that our brains are more controlled by the context in which we find ourselves than by our internal states. So as outside, so inside. So there's a sadness circuit. There's the seeking circuit, which is also called the reward system, and probably the dopaminergic reward system is the more common nomenclature, but number of studies have shown that seeking activates this system more than finding. And of course, bipolar disorder, mania, could be construed as excessive seeking. There's the attention orienting system, which is considered to be largely noradrenergic. The sadness circuitry is considered to be largely serotonergic. There's the story brain, which is a series of midline structures with which we use to create a story about who we are and how we function in the world. It subserves the function of introspection, of telling a story about myself and telling other people who I think I am. It's partially acetylcholinergic. It breaks down in dementia, particularly in Alzheimer's dementia. There's the error detection system, which relies heavily on the anterior cingulate cortex. The executive functioning system, the fear, freezing, hypervigilance, sense of constant danger, sense of safety, which relies heavily on the amygdala, various amygdaloid nuclei. There's the excess attribution of external agency system, which is paranoia. Dysnarrativia is related to story brain. The salient system, the sleep system, emotional regulation systems, impulse control systems, and things like that. So here's a little bit about the anatomy of the reward or the seeking system. So you've all heard about the mesolimbic, mesocortical, dopaminergic system. And so in the positive symptoms of psychosis, not necessarily meaning desirable, but in the sense of something is happening, we aim to block the mesocortical dopamine system. The problem with that is that we also block the mesolimbic dopamine system, which causes the motor problems, the motor difficulties. And the second generation antipsychotics do less of that, but at the cost of metabolic effects. So we're talking about the nucleus ambiguous. Let me see if I have a better slide of that. These are rat brains, by the way. This is the guy, Jim Olds, who discovered this system. And all animals use this system. So it's necessary for survival. So we need to figure out, we need to be curious about our environment. If we're an animal living in the wild, we need to look around and find out where the water is, where the food is, where safety could be found, things like that. And the nucleus accumbens is the source, where the nuclei for these dopaminergic neurons live. And we all know about how some drugs which cause euphoria release dopamine. And so the nucleus accumbens communicates with the ventral striatum, and the more dopamine we release in the ventral striatum, the more euphoric we feel. What about the sadness system? So sadness, we can recognize it. Raised inner eyebrows, lowered corners of the mouth, reduced walking speed, slumped posture. So this circuitry goes from the dorsal periaqueductal gray matter to the subgenual anterior cingulate cortex, which is now a treatment target in disorders of sadness. And in sadness, there's an asymmetry between the left dorsolateral prefrontal cortex and the right, which is why TMS, transcranial magnetic stimulation, targets the left dorsolateral prefrontal cortex. So here's a diagram PAG is the periaqueductal gray matter. DMT is the dorsal medial nucleus of the thalamus. You can see the basalis nucleus of Maynard, the dorsal preoptic area, the ventral striatum, and ultimately AC is the anterior cingulate cortex. So there's different types of depression, and they probably involve different dysfunctions of circuitry, and probably need to be treated differently. And so depression with atypical features has been known to respond better to MAOI inhibitors than depression with melancholic features. So melancholic depression responds better to the dopamine agonistic agents. So this is the sadness circuitry. And let's go on. There's a lot of really exciting neuroscience to read, but we can't really look at all of it, can we? So anhedonia, inability to experience pleasure, reduced activation of the dopaminergic reward circuitry, particularly the nucleus accumbens and the anterior cingulate gyrus, which is why in geriatric patients with anhedonia, sometimes we treat them with psychostimulants, with methylphenidate. And I recently had a case in the hospital where we gave the patient a little methylphenidate and a little risperidone, and she perked right up and started eating and taking care of herself and was very cheerful. Sadly, it didn't improve her dementia, but she was a lot more fun to talk to. So, and you can, there is this whole interventionist psychiatric field, and it turns out that deep brain stimulation of either the nucleus accumbens or the anterior cingulate cortex reduces anhedonia and treatment refractory depression. So, anxiety. We're looking at disturbed connectivity between this frontolimbic circuit, which we call the fear circuitry, which includes the dorsolateral prefrontal cortex, the ventral medial prefrontal cortex, and the insula, with the posterior cingulate and occipital areas that support perceptual processing. And this fear circuitry is heavily involved with the amygdala, the hippocampus, and the parahippocampus. So the amygdala, which means almond, there are two small almond-shaped structures located in front of the hippocampus near the temporal poles. And they're involved in figuring out what's important and what's of significance in our environment. They're critical for negative emotions, especially fear, because it turns out that it's more important to recognize danger than it is to recognize safety for survival. And so Schwartz showed in a landmark study that we can change the functional connectivity with the amygdala through psychotherapy. And before that study, philosophers of mind like Dinbar had argued that thoughts are like the steam produced by a locomotive, that they demonstrate the presence of thought, but they don't do anything to the underlying structures that produce the thought. Schwartz showed that using psychotherapy for panic disorder and for OCD actually changed the connections and the number of functioning neurons in these brain areas. So, so what he did was to improve the capacity of the prefrontal cortex to tell the amygdala to chill. So simply put, it works somewhat like this. If I see a stick on the path and I happen to be hiking in Arizona in rattlesnake country, my amygdala is going to go, holy whatever, there's a snake on the path. And I might jump. But my medial prefrontal cortex is going to say, dude, it's not moving. It's not rattling. It's just a stick. Chill. And my amygdala goes, oh, okay, fine. All right. And if the connectivity is dysfunctional, people can't do that. They can't tell their amygdala to stand down. So, so this is really important for anxiety and fear responses. So there's so much to talk about with limbic systems. But how about, here's another system that's extremely important for us, which is the social belonging system. The feeling that I belong, that I have a home in the world. And it's mediated by endogenous opioids, by oxytocin, and by prolactin. And it's why touching is so comforting, is because when we touch each other, we induce the release of endogenous opioids, oxytocin, and prolactin. And this response has been shown to be blocked by naloxone. So, so why are opiates so desirable? Because they give us that sense of belonging. And it turns out that the brain has a shared circuitry for social and physical pain, that your brain cannot tell the difference between physical and social pain. It all gets mixed up together in the anterior cingulate cortex and gets delivered to the frontal cortex as a package that says, I'm in pain. Which is why we have so many metaphors in English for emotional states. For example, we say that someone broke my heart, or that they stabbed me in the back, or that they're a pain in my neck. In Russian, for example, just to show you an interesting cross-cultural difference, pain in the neck translates as they're standing in my liver. So different cultures have different ways of expressing that, but in all cultures, there are physical metaphors for social pain. And over 2,000 years ago, the Greek poet Antiphanes understood this when he said that pain is one malady with many names. So, there is this overlapping circuitry between emotional pain and physical pain. And this is why opiates are so desirable. And it's why we have to work to change, we have to work on this circuitry in order to help people to overcome opiate use disorders. And part of that work is to help them to feel more belonging. All right. So now I'm going to talk a little bit about some cases because we're running out of time, and I just want to briefly show you some of the areas of the brain involved with error detection, salience, pain, and you can see that they're very similar. So I did want to say, I wanted to talk a little bit about mania, and to say that the reason that, so there's the reason we treat mania with dopamine blockers or anticonvulsants is twofold. So the dopamine blockers reduce the hyper-seeking behavior, and the anticonvulsants slow down the brain. And if you slow down thought, people have a chance to evaluate their actions before they take them, and their judgment can improve. So, all right. So now I want to make some conclusions, and then I want to talk about some cases. So my conclusions are, ignore the noise. There's always studies appearing that say that drug X is better than drug Y for any given condition, but wait for the meta-analyses. Don't jump on the latest bandwagon. DSM is good for billing, but not for understanding the patient. More drugs are rarely better than less drugs. This idea that if only I'm on the right meds, I'll feel great, rarely happens. Also, we need to demedicalize sadness and worry. So everybody has every psychiatric symptom, but it doesn't necessarily mean that medicating them is the best choice. And that lifestyle change and psychotherapy really work. So now I want to talk a little bit about how do we work with this? So, okay, so some of it is not that dissimilar from what you're already doing, but the point is to begin to wonder what brain circuits are dysfunctional. In what brain circuits is there a lack of connectivity? And so for instance, probably the most common symptom that we see is anxiety. And anxiety is appropriate for many people. They have lives in which they need to worry. That worrying could be good for them. However, perhaps they worry too much. And medications will not necessarily change that. But if we want to prescribe a medication, we want to target the amygdala and the frontal cortex. So we want to target these fear systems. So how do we do that? Well, SNRIs, SSRIs are probably our initial modality. That we want to figure out how to alter serotonin functionality and norepinephrine functionality. Okay, so we might start with venlafaxine. We might start with fluoxetine. We need to be aware that high doses may be needed to treat anxiety compared to the doses we're usually used to. Similar for OCD, that higher doses may be necessary. And that if one drug doesn't succeed, try another. And at the same time, work with the patient in terms of changing lifestyle, engaging in psychotherapy, learning how to reduce their worry. And there are so many techniques for worry reduction. There are apps, there are apps for meditation, apps for Qigong, apps for Tai Chi. Exercise is amazingly effective. Reducing caffeine and sugar is effective. That we need to do more than just prescribe medication. Sadness. So many of our patients have a lot of reason to be sad. And also, I want to point out that when our patients are living in situations that are dangerous, that it might actually be contraindicated to try and take away their fear or their anxiety, because they might need that fear to stay safe. And I'm talking about situations of domestic abuse, domestic violence, living in shelters, living on the street, things like that. Sadness. What are we going to do about sadness? Well, again, serotonin. So we start with serotonin. We might start with fluoxetine. And we might, if that doesn't work, we might try another medication in that class. If that doesn't work, we might switch classes. We might try bupropion. We might try mirtazapine. And remember, it's more important to base drug choice on desirability or lack of desirability of side effect profiles than it is believing that one particular drug is more efficacious than another. If I get a partial response from a particular medication and I'm at the maximum for that medication, or I've increased it and I'm getting side effects, I typically add an augmenting agent. So for depression, I might add aripiprazole, I might add lurasidone, I might add risperidone, I might add low-dose lithium, I might add T3. So I might add an augmenting agent that addresses another circuitry rather than giving up on a drug when I've got a partial response, but I can't go any higher. What about mania? Well, I typically will start with a second generation antipsychotic, and the lower the dose, the better. And if I max out on that, I'll try an anticonvulsant to add or to switch to if the antipsychotic is not working, the dopamine blocker. Now, when do you consider lithium? Well, anytime really, but lithium scares me because it adversely affects the kidneys and the thyroid. And I have seen so many cases of lithium-induced nephrotoxicity or thyrotoxicity. On the other hand, sometimes it's the only thing that will work. And so sometimes we have to bravely go where no one has gone before and try something that might have adverse effects. So in retrospect, looking at this as a whole, we want to stop thinking about the diagnosis and start thinking about the neural circuitry that we're targeting, and start wondering about what neurotransmitters serve that neural circuitry. And we want to realize that much of psychiatric prescribing is not rational or based in science, and that we can improve upon it. And I will say that what we've discovered in teaching our residents, our family medicine residents, from this perspective is that they've become much more comfortable with all classes of psychiatric medications and all categories of symptomatology. And their need to refer to psychiatrists has decreased dramatically. It's gone down by 80%. And I think that's a good thing because there's not a lot of psychiatrists in northern Maine. So with that, I'm going to be available for questions. And I want to thank you for paying attention.